I'm going to make a bold statement, and I'd love this to be the basis of our conversation. In my experience, and the statement is that at least 5 to 10% of kids who have ADHD and or anxiety and whatever other behavioral issues, the root cause, the origin, the entire reason why they have ADHD and or anxiety, and usually they have both, is because of something that has gone on in their mouth. So we're calling it a broken eating mechanism, just for people to understand. So something has gone wrong in the mouth, whether it's something to do with the tongue or the actual complexity of the eating. And we'll talk about that a little bit. But everything that has come about, the whole reason why the child has ADHD or anxiety is because of something that started in the mouth that was there probably from the very, very beginning of the child's life. Now, the two of you have seen hundreds, if not thousands of patients, and this is your cup of tea. Would you say that that is an accurate statement, that at least 5 to 10% of what looks like ADHD and anxiety may actually be a problem with the mouth and breathing and so forth?
Definitely.
I would say that's actually quite conservative.
Me too.
10%, but it might be much, much more, because when you're talking about feeding in the mouth, you're also talking about sleep and breathing and nutrition, and all the sequelae of not being able to feed right from the start can have terrible sequelae down the road, as I'm excited to talk to you guys about.
Both of you have said that you think that that's a conservative statement. So between autism spectrum, anxiety, and ADHD, I mean, if you were to give a number, and obviously it's hard because we don't have hard data, what would you say? 10%, 20% may actually be all tied to the mouth?
What I would say is just flip the question around and ask people whether or not what you eat affects your mood and behavior. And if you just kind of consider that, if you have a lot of caffeine or coffee, how's that going to make you feel? How's that going to make you act? If you're having a lot of sugar and corn syrup, what effect is that going to have on the way that you feel and the way that you behave? And it turns out that in our current medical environment, if a child is born with a problem like a tongue tie, for example, where the tongue is physically tethered to the floor of the mouth and they can't properly breastfeed, the answer is formula feeding, Similac, with products and the main ingredients of them being corn syrup and vegetable oil.
The foundation of our health starts with our ability to eat. Right. And that's kind of fundamental, right? And I hope everyone can appreciate that is the truth. And one of the things, and I'll kind of speak for myself in my community and why I thought of bringing, the two of you together, is one of the things that I see is that in our holistic medicine community, where people are a little bit more aware, there's still very little awareness around what happens here. Right. And I see the patients that have gone to other docs where they've tested the gut and they found fungus and they found this and they treat this and fix the gut and change the diet and get rid of gluten. And no one noticed that this kid literally doesn't know how to eat.
What we're seeing is every kid that has a speech problem also has a feeding problem that has not been identified. And I have 11, 12, and 13-year-olds that people have not treated for feeding. They munch 3 times in the front and they swallow the food whole. And I'm not kidding. People have been working on their speech forever, but they never looked at this.
They don't look. And that's one of the things that I found interesting and a little troubling, that just because someone has seen a speech therapist, we presume that everything is fine in the mouth. So Diane, you're basically saying not all speech therapists know how to find tongue ties and other disorders within the mouth.
Yeah, we had a 20-year gap where we focused. See, when I went to school in the 70s, we were trained. I had 3 articulation courses, 2 voice courses, 2 fluency courses. I had a course in cerebral palsy. I worked with very difficult, very involved populations most of my career. So I had a chance to problem solve and work with OTs, PTs, everybody. But today we're seeing a lot of, Dr. Zaghi can tell you how many, because we have them show us the children eating,
Mm-hmm.
almost none of them are chewing at the back, at the molars. They're taking like 3 munch bites up here, swallowing their food whole, and we know digestion begins with the saliva. So we should actually be chewing 20 to 25 times, but I'll take 10 to 15 at the molars if I can get it.
And Dr. Zaghi, from a surgeon's standpoint, because you deal with this surgically, mechanically all the time, can you help our audience understand how a tethered tongue or a tongue tie would ultimately limit an ability to eat? And I know, Diane, you've got a lot of wisdom in here, but from the surgeon's standpoint, mechanically
I send them to
speaking.
Dr. Zaghi. I
Yeah,
do a Murphy maneuver and then I say, go see Dr. Zaghi.
So when you eat, it's more than just chewing. You actually have to move the food from one side to the other. And if food gets stuck somewhere, you have to get your tongue in there and swoop it back in. And so feeding and chewing is actually a mechanism that requires both sides of the cheek, and the tongue is the processor by which the food moves around and ultimately gets swallowed in. And the way that you chew and the way that you swallow actually affects the way that the teeth develop and the bones develop. And when you have good chewing and good swallowing habits, the teeth grow wide. And when you have wide skeletal structure, that helps support the airway.
Right. And back to why speech language pathologists are just getting trained in this again, is that we switched from being speech therapists to speech language pathologists, and we started really focusing on language and cognition. So there weren't many of us, I mean, only those who worked with people that had a lot of oral problems for feeding, who really got well trained in it. So now we're catching up.
The swallow aspect of it, right? Because it's speech language, but it's a speech and swallow
Yeah.
It,
Well, and swallow is so easy to feel. If it's by the age of 2, a child should be eating like us, and that's not happening. And it's not. And this is a no guilt thing for parents. Parents just don't have the information, like you shared those books. That's why I wrote those books. I worked in a Down clinic with children with Down syndrome. We saw about 45 a week. We could keep them on track if the parents did what we taught them. If you can keep a child with Down syndrome on track, we should be able to keep our typical children on track. And we also know, back to autism and ADD and ADHD, we're seeing a lot of muscle tone issues in the children. And now I just wrote an article for the Autism Advocate Parenting Journal magazine. And, you know, I found lots of literature on low muscle tone in children on the spectrum. And actually, the spectrum started out from the ADD, ADHD group through autism, but now we've redefined it. But a swallow is right here. You take your fingers on your masseter or mylohyoid, and then you swallow, and you should feel contraction, because the jaw has a lot to do with the swallow, and that area gets worked well with breastfeeding. It doesn't, only cheeks and lips really get worked with bottle feeding for the most part.
Dr. Zaghi, you were commenting on how if the tongue doesn't move, if there isn't proper feeding, you basically don't get proper jaw development. So to help people contextualize that, so if you've got a kid who has a lot of crowding in their teeth and their teeth are kind of sitting on top of each other, the palate is really tall and really narrow, that's actually a sign that there's an eating disorder and probably a tongue disorder. Is that correct?
Absolutely, and I'm sure Diane can explain it better, but you need to
have a nasal disorder. I mean, these were my expanders, and I had a tongue tie, but Dr. Zaghi would not release it because I needed more room in the palate in order for my tongue to have space to be released. Go ahead, Dr. Zaghi.
That's exactly right, and it turns out that just like Diane needs to have orthodontic work to expander, in kids, that orthodontic treatment, those palate expanders, are actually the innate tongue and the lips. And so the way that the tongue and the lips move and the pressures that they put is what is creating the forces necessary to help grow the bones.
Right.
And when you have a mature swallow, it grows wide and broad. But when you have low tongue posture and you're doing cheek swallowing, as Diane will explain, or bottle feeding, the face starts to grow narrow and inwards because the cheeks and the lips are doing more of the work rather than the tongue and the jaws.
Wow.
And babies are generally born with the tongue sitting in the palate and all the structures very close together. But if we don't release, I saw one child in the first week of life, and the lactation consultant sent him, and he had, everything was beautiful. His muscle tone in his body was beautiful. His suck was beautiful. His back and base of tongue was moving beautifully. He only had a little stringy tongue tie. So the parents waited to get it released until he was a couple of months old. And now guess what? He has feeding problems.
Just so people understand exactly what we mean by a tongue tie, because I mean, some people know of it, some people don't. And I mean, I have to admit my own ignorance when a few years ago, when I really got into this world, like I was like, hey, yeah, I know how to find the tongue tie. And I realized like, I still don't know how to identify all of them. But so a lot of people, when they think of a tongue tie, they think of basically this thickle band that's in the front of the tongue that, you know, anyone would look and say, oh, wow, that's a tongue tie. And that is one type of a tongue tie, but that's not the only type of a tongue tie, right?
Yeah, so Dan's showing her tongue tie, right? So we're moving away from talking about just tongue tie and talking more about tongue mobility. And when you're looking for tongue tie, you want to see, of course, can you stick out the tongue, but more importantly, can you lift up the tongue? So when you lift up the tongue, as Dr. K can do, it's moving up just fine. But there are some patients who have difficulty lifting up the tongue. So what they do is they engage the floor of mouth and they push up the tongue.
Yeah.
And that's what we're seeing is Diane doing that. You're pushing up a little bit. So
my whole floor of my mouth has come up.
Yeah. So you can't really see the attachment because they're so glued together that when you're lifting the tongue, it's not the tongue that's lifting, it's the floor of mouth that's pushing up. Yeah. Now, if you do good therapy, well, then you can isolate the floor of mouth down and lift up the tongue. And then sure enough, you'll see that string in there, holding it down, tethering it down.
And I think the other thing, go ahead, finish.
The tethers can be in the front of the tongue where it's really obvious, or the tethers can be in the back of the tongue where it's less obvious and it's more of an attachment to the floor of the mouth. So when they lift their tongue, they're able to do things, but they're doing it with their neck and their floor of mouth rather than the actual tongue muscle. And these are the more difficult to diagnose ones, the posterior tongue ties or the submucosal tongue ties. And it turns out that it's those that actually can cause some of the more subtle effects that don't get diagnosed outright, but that sneak under and cause problems with nutrition and swallowing and the gut microbiome and sleep and breathing that ultimately results in a diagnosis like ADHD, autism, or whatever it is.
Right. And I think the thing is, a key word Dr. Zaghi just mentioned is therapy. So if a baby has the tongue tie diagnosed at birth, and then we have it released, that child's been sucking, we know from Dr. Guilleminot's work and others, that child's been sucking lots of amniotic fluid in utero. So even if they're released at birth, they need to be looked at for that mobility piece. But also, Dr. Zaghi's called me up and on my day off, not that he knew it was, but you know, I'm in the middle of Popcorn Girl, I like to tell this story. And he was seeing one of my older patients, a 20-year-old from England. And he said to me, well, I need to know what treatment you've done up to now so I can make my decision. And then what are you going to be doing? That patient was in my office, saw Dr. Zaghi on a Wednesday. He was back here in Las Vegas in my office on a Monday for treatment.
a way I'm a simpleton in certain ways, and I try to simplify things. So part of what you're talking about with the therapy is I kind of tell parents, it's like if your arms have been shackled to a chair pretty much your entire life, and someone comes and cuts the chain, except you've never moved your arm, you need a therapist to actually help you move your arms, because otherwise your arms are just kind of sitting there flaccid. And that's kind of what you're talking about, that it's not just snipping that connection, that shackle. And tongue ties are basically the tongue is shackled to another part of the mouth that's preventing the tongue from moving. And just because we release that tie or that shackle, there's still therapy that needs to be involved in getting the tongue to move.
And the best therapy is appropriate feeding therapy. You know, so it's actually so easy. Chewing back here at the molar areas, we can stimulate even in brand new babies. They have this thing called a phasic bite. That chewing back there, whenever it is, that's what builds and forms your jaw bones, your upper and lower jaw bones. In addition to how the tongue is sitting in the mouth, as Dr. Zaghi was saying. So good feeding therapy, just learning to feed your child properly, can really help with, you know, the post-treatment. So a lot of parents, you know, they take for granted, and adults in general, they just take for granted how they eat. Believe me, I don't anymore right now, because I'm having to learn to eat a new way. However, I have done orofacial myology on myself since I was 30, because I had braces back then. So I'm very aware. But we gave our participants in our course a 30-day, and they're adults, a 30-day page where they have to write down what they're experiencing. We have these good eating and drinking guidelines. This is the kind of thing the parent can put on the refrigerator to remind them. And we want the whole family eating that way.
That's amazing.
And simple.
And just carrying on Dr. Catarai's example and what Diane just mentioned, if you're shackled, you're not going to know how to use your hands. But there's another even bigger issue. Even if you don't have a tongue tie, the foods that we give and the manner in which we give it, can be delivered in such a way that you're not using your tongue. And simply by not using your tongue, you have the same effect that the tongue becomes flaccid out of disuse. And so in the book, Feed Your Baby a Proper Right, Diane goes through all these things about how the kind of cups that you use and the kind of foods that you give, and those, you know, baby food pouches that look so attractive on the grocery aisle, right?
Yeah.
Could be a setup for a dysfunctional tongue and swallowing and feeding mechanics, that even if you didn't have a tongue tie, your tongue is acting like it did, and you get the same oral.
It hasn't learned to move. So, you know, I'll tell people, you're going to be surprised at what I say often, because all I really need to do is teach you how to get the tongue cupping and grooving, the tongue tip mobility, the chewing at the molars, and you eat 5 times a day if you have snacks. So you could be practicing throughout the day. And we often start, I just saw somebody from Australia on Saturday with an orofacial myologist. And we also start a lot of times with dental hygiene, because many times the children, because they haven't moved food, or they haven't placed their fingers in their mouths, or they've done a lot of sucking of everything, a lot of those kids really need to develop what's called oral discrimination, which would normally develop around 5 months, but with all the pouch foods and everything else. And even baby-led weaning is often misused. I like baby-led weaning, but a lot of times people just use the first piece of baby weaning. And those are the kids that kind of get stuck with food being right here.
So really getting kids to eat a wide texture of foods and complex foods and so forth is really important, because that all of that creates the future foundation for eating.
Right. It takes a number of exposures of foods, 10 to 15, for you to begin to accommodate to it. And if you don't like the smell of something, which is a good reason to keep the nasal area healthy, you're not going to want to eat it. And you know yourself as an adult, if you tried food from a different culture, maybe you didn't like it so much the first time. Then after a while, it became one of your favorite foods because you had more exposure to it. So we have to have the exposure to the taste, the textures. I've had two parents lately, one in North Carolina and the one this weekend in Australia, who I was very pleased with because they had exposed their babies to so many different tastes and not textures yet because they didn't know how to do it. That's usually where people get stuck, is the textures.
Okay. Let me ask you this from a tongue tie standpoint, based on your expertise and experience, what percentage of the population would you say has a tongue tie? Just for people to understand, is it 5%? Is it 10%? If you were to just take random people off the street, how prevalent is this? Because I don't think a lot of people understand this, that it's actually way more common than we realize. We just don't know how to look for it.
I think it's at least 5%, likely 10%, and at most 25% of the population.
Yeah.
Wow.
So it runs in my family. I have one. My daughter has one. My daughter does funny things though. Because she's got the posterior tie, she can take the tip of her tongue and tie a cherry stem in a knot. And we don't have the kind of restrictions because we're both feeding therapists, partially, and orofacial myofunctional people. We have made it our job to have a good oral phase swallow, to manage our food well, to be on a good diet, but not everybody is. And so when I teach, people will often say, you asked actually, Dr. K, about the picky eaters. Well, children do go through times where they eat more, they eat less, they'll have their favorite foods, things like that. However, if somebody is really picky, there could be a medical problem like reflux. Okay, there could be an upper airway problem that always needs to be looked at, or they just may lack experience, as Dr. Nagi said. So people will say to me, well, I have this kid, and the kid only eats McDonald's French fries and chicken nuggets. And I say, and we call some of those nuggets, they're not all this bad, but they're ground meat. So therapists will call them pre-chewed meats. So you don't really have to chew them like you would chew like a piece of stewed chicken. And they're also the kids that are munch, munch, munch and swallow food whole, end up with speech problems later on, and speech and feeding are two completely different processes beyond a year of age. However, they are related, and we're seeing that in the course that we're working on right now, how related they really are. And we're now getting literature to say that. So I say, okay, so for that child that's only eating McDonald's, what does his family eat? McDonald's.
Yeah. But, I love that you're bringing this up because I see the other side of this. And I think this is one of the things that all of our audience needs to pay attention. I hope everyone really hears your wisdom because
I'm not picking on McDonald's. It could be Burger King, any fast food.
But, if 1 in 10 or 1 in 20 people have this, and part of the pattern that I see, and I see the 12-year-olds and I go all the way back to birth, is yes, they either had a very painful latch, or they couldn't breastfeed at all, or they couldn't transfer. So the mom, at a certain point, the kid starts losing weight. So they have that pattern early on. Then when I asked them, about, well, how were they doing when they were about 1 year to 2? Oh, they would choke and gag all the time. And we had to give them X foods. And I was like, and one of the things that I asked them is like, when your kid was 1.5 years, 2 years, could you give them a piece of chicken or some kind of dense protein? And can they eat it? And a lot of times the parents are like, no. So there's this pattern where there's the breastfeeding issues. Then there's the choking, gagging, spitting foods out.
They haven't worked through that gag. I mean, we give them a very specific massage that's easy to do in the mouth as part of oral hygiene. It can be done with cheesecloth on a finger, whatever. We have tools starting with that a 3-month-old can be exposed to. What we're finding is kids aren't mouthing, they're mouthing in utero because you see it on the ultrasounds, but they're not doing the things like putting their hands in their mouth and working their own gag back through the process of experience.
Diane, that's a very, very important point that you brought up. Can you talk a little bit about that age range where, pacifier and oral habits, and when it's normal and when it starts to become abnormal? I think it'd be very interesting for the audience.
Well, there was a study done in Finland that most pediatricians used to know about. It's gotten old now, but they looked at about 500 children. And what they found was they wanted to see if there was a connection with pacifier use and middle ear problems. And so middle ear problems are caused by a problem with the eustachian tube. A lot of times it goes from the back of the nose and throat area, to the behind the eardrum area. So what they found was that if children used pacifiers up to 10 months of age, they didn't have an increase in middle ear problems, but beyond 10 months, they did. However, they also made a set of recommendations of where they think, and Dr. Harvey Karp also kind of goes along with this in his book, where they said, look, start to wean your baby from the pacifier at least by 5 to 6 months of age. And so I have very specific guidelines in my book about this. And we need to get kids chewing, chew at the molar areas. And this is the kind of thing that can go all the way back here, made from medical grade materials, called a Beckman Tri-Chew, also made from medical grade materials. This is the size of the chew. We get kids when they're older and they're safe with these. They do discriminative mouthing with them. Spoons are great for discriminative mouthing. Here's a dipper spoon right here that the child can dip and do this. And also families aren't eating together. That's a big problem because kids have these things called mirror neurons. And so if you're not doing something, they don't want to do it.
Yeah, it's all so critical.
Yes.
It's all so critical. And, I think these factors and, just a child's inability to eat and, this is what I really hope people walk away with, that if your child doesn't know how to eat, and this could have started from very, very early on, what we call the picky eater. And typically it's the kid that eats mac and cheese and chicken nuggets, plus or minus pizza, and that's about it. And a lot of parents don't really appreciate that, like how significant these things are. And you know what? Some kids are just, they're at 3 or 4 years of age and they're just being a pain in the butt, but they were eating everything before. But there were also kids that have never been able to eat for all of the reasons that you said. And, this is one of the things that I really want people to see, because when your kid doesn't eat, and all they eat is dairy and wheat. And it's not that dairy and wheat are evil by themselves, but if that is all they eat and that's all they've ever been able to eat, guess what happens to the bacteria in the gut? They change. And Dr. Zoggy, one of the things that you taught me is that when we have a tongue tie, because of the fact that the tongue is not sitting in the right position, that starts causing airway issues, right? And if we've got all of this basically grain and dairy that's going into the gut, and you've got a sleep problem on top of that, that is a combination for a disaster of a mess to happen physiologically. And there is no human body, well, not many human bodies that can handle all of that stress and not develop ADHD and anxiety. And that's one of the things that I see in at least 5 to 10% of the kids that I see, that they're coming in because of severe anxiety and because my kid can't pay attention and they're all over the place and blah, blah, blah. And they're expecting me to give a supplement to fix it all. And then as I start going through the history, never breastfed.
Right.
One-year-old that was spitting out food. Now they're the 11-year-old that can only eat a limited number of foods. And that's all they've been able to eat forever. And they toss and turn and they choke and gag while they're sleeping. And then I tell them, like, you need to go find someone to look at the airway. So Dr. Uzagi, can you touch on that in terms of how the tongue ultimately can cause an airway issue? Because if we can't breathe, we can't think, right?
So absolutely. So the tongue is actually the switch lever that determines whether you breathe through your nose or through your mouth. When the tongue is up, the only way to breathe is through your nose. You can't breathe through your mouth because the switch lever is up. You have to breathe through your nose. When the tongue is down, either because of a tongue tie or because it's weak, low in tone, or doesn't know simply how to get up, you're going to have either mixed nose and mouth breathing or exclusive mouth breathing. Now, the problem with mouth breathing is that mouth breathing is hyperventilation. Mouth breathing is hyperventilating, okay? So when you breathe through the mouth, you expel a lot of carbon dioxide and you can get lower CO2 levels, and that can trigger an anxiety feeling. You can just try to hyperventilate and you start to feel a little bit anxious. And you don't recognize that when these kids are hanging out with their mouth open, they're hyperventilating, they're having a metabolic shift, and that's physically making them unwell because they're not breathing appropriately.
And if the palate goes high and narrow, what is the palate? The floor of the nasal area.
That's right.
The turbinates start to go like that.
Yeah, so as you mouth breathe, the body assists you, the turbinates hypertrophy, the palate gets more narrow, so you become more of a mouth breather, and so the problem continues with that hyperventilation. And the more that you hyperventilate, the gut microbiome is in a less carbon dioxide rich environment, and that changes the bacteria there in the gut, and that has sequelae all the way on.
And I was the kid with ADD who girls compensate better than boys, so I always was a great student, but I remember how hard it was for me to attend and how exhausted it's exhausting. And then Dr. Zaghi and my other doctor identified my airway problems. So I now sleep with a CPAP while I'm going through all this, so I make sure that I'm breathing well at night.
Yeah, absolutely.
How does this, so the hyperventilation is the first phase of this, but one of the things that I've seen, and you were the one that really taught me to pay attention to this, a lot of these kids go on to oftentimes develop actual obstructive sleep apnea. So how does that correlation come about? So we've got the first sequelae, which is a mess by itself.
So then that causes stress. So the mouth breathing, the hyperventilation is a stress on the body, and stress on the body results in increased levels of cortisol. Increased cortisol levels is pro-inflammatory. You get more acid reflux. You get more inflammation in the mouth, in the gums, in the tonsils. And as the tonsils are inflamed and you're having acid reflux and you're having mouth breathing, the tonsils can become hypertrophic as they get bacteria and food trapped. And the tonsils and adenoids are overwhelmed with all the pathogens and inflammation, and they can block the airway. So you have soft tissue obstruction from tonsils and adenoids, and you have hard tissue obstruction from the teeth, because the teeth and the jaws support the airway, and the teeth also, the roof of the mouth is the floor of the nose, as Diane said. So if if you have a high arched palate and your upper jaw is underdeveloped, your nose will be underdeveloped, your nose will be smaller, and further more difficult to breathe.
And that was my palate to start with.
Wow. Wow. So it literally, it's like this domino effect, Diane. I think you pointed that out. It's literally a domino effect. One thing hits another, then you've got the hyperventilation, you've got all of this CO2, you've got the reflux, and next thing you know, you've got tonsils and adenoids that are enlarged. And that combination physiologically is just so like profoundly stressful to the human body that, you know, it is definitely the reason why I see some kids with ADHD. And it's the only reason. Like, I mean, ultimately their guts are a mess. They have tons of food issues. And that's the other thing that I've found. A lot of these kids develop these abnormal guts where now they're reacting to everything because the bacteria are off. They've got this inflammatory response in their gut, which causes their entire system. And it's just this really cascading snowball effect where it's just one thing hits another, and then that hits another, and now you've got the enlarged tonsils and now sleep apnea, and then it becomes this disaster of a mess that really overwhelms the child.
And Dr. Catterai, you know, I don't want to open a can of worms here, but with you and very skilled IBCLCs seeing more typical babies being born with low muscle tone, my question is, like Dr. Guilleminault said, this is a collapsible tube. And that I'm sure Dr. Zaghi says the same thing, but what happens when you have gravity with a low tone person pushing on that collapsible tube? And they're starting to do some research in Europe on this. But one of the things we're stressing in our courses is not only appropriate feeding, but appropriate body positioning to help those kids who start out with that low muscle tone.
That's fantastic. Let me ask you guys this. So a lot of people are now scratching their heads, and hopefully this video and discussion really gets to a lot of people and has people start really thinking, because I mean, I hope that our holistic medicine community and parents in large don't just obsess with the gut, because the gut is important. You know, eating healthy foods that are non-inflammatory is important. But if a kid doesn't know how to eat, you can't just say, well, go on a gluten-free diet and go on a dairy-free diet, and here's a probiotic and have a nice life. The kid can't eat. And we have to address that first.
Right.
To open things up, to get the tongue moving, to get the palate in the right position, to get the airway to open up.
We're seeing so many jaws because we have people in our class taking certain kinds of pictures of posture, of face front, face side, in the mouth, you name it. But we're seeing so many children who do not have developed lower jaws, and they have mid-face deficiency, which speaks to the upper jaw. So with the jaw as a foundation, if you don't develop those, then it's very hard for the lips and tongue to do what they need to do.
Where would parents turn to? So obviously, I wish everyone had access to the two of you, but that's just not possible. Where would parents turn to? So let's say they look and they say, shoot, my kid never breastfed. They choked and gagged and spit the food out early on, and now they're the 10-year-old that only eats mac and cheese and peanut butter and jelly, and they toss and turn in their sleep. They potentially choke and gag, and yes, they've got ADHD and anxiety. So let's say that's the profile.
Yep.
Where do parents turn to in their community to have someone accurately look and say, yes, this is what your kid has and this is what you need to do? Where do they find the resources?
Well, hopefully they've already been, we just talked about this last week. Hopefully they've already tried to breastfeed and been to the lactation consultant. If they have to bottle feed, you can find proper bottle feeding. That's what I have in my books, and a feeding therapist like me will help you do that. And there's a group called Feeding Matters, which is multidisciplinary like we are. And so when you go to the Feeding Matters directory, you can usually find a feeding therapist in your state that will help get that back on track. But we also need airway-centric ENTs. I mean, I'm not criticizing ENTs, but every time I walk into the office, they cringe because they know I'm going to bring pictures of, you know, I was looking for one of a little boy I had here, which in 6 weeks, his jaw, he was 18 months old. He only sucked foods. He only screamed. He was born typically. And in 6 weeks, with appropriate jaw work, that's not hard to do at all, we got his jaw growing. And so you need your lactation consultant, your feeding therapist, your airway-centric ENT, your holistic pediatrician. As you get older, you need the oral facial myologist. And so I had the oral facial myologist because the child in Australia had been to everybody else. And so now to the oral facial myologist. And so we started with oral massage and toothbrushing and working on the gag by brushing the tongue. And that's very much part of what they do, because they come from, many of them, because this one came from the dental community.
So one of the things I appreciate you pointing that out. So one of the things is, just because someone goes to the ear, nose, throat doctor and the doctor says, no, your kid is fine, that actually doesn't mean that everything is okay.
Because not every feeding therapist is the same. Not every speech language pathologist is the same. It's why we opened up this program, because, and believe me, it's been work, right? But it's why we opened up this program, so we can get people from different disciplines kind of on the same page to start.
Certainly, not every pediatrician is the same, Dr. K.
Right.
And you're going to get various different opinions depending on their background and training. So what we're trying to do together is train doctors and dentists and speech therapists and dental hygienists to all speak the same language in order to be able to see the mutual problems and how we can work together. And I think it's going to take leaders like yourself, the primary care doctors, to develop the communities in the different neighborhoods. Because I know that any of the patients in your practice will know exactly where to go and who to go to. And so if we can get more pediatricians and medical doctors aware of these issues and building their communities, then we can certainly provide the education necessary to really make a difference.
And we are scattered around. So there are those of us in different locations. One of the things we're trying to encourage is them, because everybody's so encapsulated these days.
Yeah.
They're not all in one facility like I was at the Maryland School for the Blind, where I had all the Johns Hopkins doctors who came to our beautiful campus. Or Maryland General Bryn Mawr. Bryn Mawr was one of the top rehabs where everybody was right there, and we treated our patients 3 times a day. So we don't have that anymore. And so somehow, and eating, drinking, and speaking are habit systems. So we have to slowly change habits by helping parents put things in their daily routines.
Yeah. And maybe if there's any directory of, potentially like people that have graduated from your courses and trainings, and I know Dr. Zaghi, you've done some trainings also prior to this collective that you guys have that we can share, because I think that these resources need to be out there, and we need to create awareness around this. And the discussion needs to go beyond just, hey, treat the gut and everything gets better, because that's actually a false understanding. The gut is super important. We need to treat the gut. We need to fix the bacteria. We need to address food issues. We need to first teach a child how to eat. And if they can't eat, all of those other things that we're doing are a complete wash. And I've seen that. I get the kids who have gone through elimination diets and gut protocols and everything, and now they're coming to see me because nothing worked. Get the mouth working, get the child eating, get the child breathing, and then address everything else. So let's, if you guys are okay with this, let's share these resources for people to get. And let's together change this perspective and help the kids who are suffering, because that's what this is all about, right? We all want to help kids. We all want kids to be healthy. And we really just want a better world for all these kids who are really struggling right now.
Right. And it is so funny to see when we're getting our participants to just do this, because this is ultimately what the orofacial myofunctional therapist wants everybody to do in terms of eating and drinking and swallowing. And even they're having trouble with it. So I remember I was with an orthodontist in Australia, and he and I both believe that we should chew our foods 25 times and mix it with saliva, bring it back to the cup center of the tongue. And so you have to have good tongue tip in order to collect that food and get it back. You have to have good cheek movement, just enough so that food doesn't get lost in the cheeks. And then you have to swallow over the back of the tongue. I'll tell you, this guy and I, we had the quietest dinner ever because we both are chewing our food 25 times.
Dr. Zaghi, any words of wisdom from you before we?
No, I just want to congratulate you for creating
Yes.
this forum and for parents who are eager and interested to learn about a different way, because I think there are a lot of families who are just not making sense of the information that they're getting. And, you know, I am so excited for this forum that you're creating so parents can go through and see what makes sense to them. And, you know, thank you for all the work that you're doing to make this possible, really.
Yeah, I think, you know, it takes a village, so we're part of that, thankfully.
Yeah.
And I know I feel very blessed to have found both of you.
I mean, I can't thank the two of you enough, because you have really helped inform me to better understand these areas. And if it wasn't for the two of you and, you know, some of the other mentors that I've had, like, I would be completely clueless. And I would be one of the other docs that would just go after the gut and just try to eliminate foods. And I'd miss this bigger picture. And this is really, it's about the whole child, understanding everything from A to Z and how everything comes together to ultimately create health or create struggles and disease. And we want health for everyone.
And Dr. Zaghi has done a really good job of creating a clinic where everything's not in place yet, but will be, where we'll have the different disciplines together. And
awesome.
that is, and there's one other clinic I'm working with right now that has a variety of disciplines. And it's so much easier to do like a lunchtime chat and problem solve with them. And, you know, a lot of times, like the person in Australia, I was problem solving with the mother and the therapist so that they have support. And the work is not difficult. That's what makes me like, what's the problem here? But a lot of people just don't have their own awareness. They don't have their parents around to show them how they fed, for example.
Yeah. And it's all about awareness. It's all about awareness. It's all about starting the discussions that get people thinking. And once we do that, then other doors start opening up.
Right. And I don't want anybody to feel guilty. No therapist, no doctor, no anybody that eats fast food occasionally. But the thing is, what we need to know is just get the knowledge, and then we'll move this forward and we'll get out of, I mean, I think it is a crisis that we're in right now.
Yeah.
We have too many, I can't begin to take all the clients who call me.
Great. Well, thank you guys so much for this opportunity.
Thank you.
Yeah, thank you. Thank you for taking the time.
Appreciate it. Thanks for putting up with this.
Be well.
Bye.
Bye-bye. And thank you everyone for watching.